Hello everyone, and welcome to Chapter 2 of DH203. Chapter 2 is the microscopic anatomy of the periodontium, histology of the body's tissues we're going to start with. So what are cells? Cells are the smallest structural unit capable of functioning independently or as a group. They form tissue. There are four basic types of tissue. There's epithelial, connective, nerve tissue, and muscle tissue. Surrounding the cells as they are floating around together is a gel-like substance that's mainly collagen fibers called extracellular matrix. This is probably kind of a review for most of you. You've had a basic microbiology class. So you have your extracellular matrix, which is connective tissue, mainly has most of the extracellular matrix, more than epithelium has. So let's start with talking about the different kinds of cells first. We have epithelium. Epithelial cells are bound into sheets, so they, like layers, forms the body's skin and lines the body's cavities. They're avascular, so they don't have their own blood vessels within them. They receive their nutrients from the underlying connective tissues. Epithelial cells can be either keratinized or non-keratinized or parakeratinized. So what does all that mean as far as keratinization? Keratinized cells on the surface, they're stronger, they're waterproof, they have no nuclei. That's the main thing to know about them, is they have no nuclei. They're usually like the types of cells that are found in the palms of your hands or the soles of your feet. They're very tough. You think of keratinized tissue as very tough, strong. Then you have your non-keratinized. Non-keratinized cells are softer, they're more flexible, they have their nuclei still. They're softer and more flexible. The way we really think of them is more like the lining of your cheeks. So if you take your tongue and you rub the lining of your cheeks, and then you take your hands and you rub them together, there's definitely a difference in the feeling of the different types of tissues. Then there's connective tissue. Connective tissue fills the spaces between tissues and organs in the body and supports or binds other tissues. So if you think about connective tissue, I don't know if you remember from dental anatomy and head and neck anatomy, we talked about fascia and spaces, and we said that fascia was layers of connective tissue that surround organs. So connective tissue fills the spaces between the tissues and organs. It's composed of fibroblasts, macrophages, neutrophils, and lymphocytes. Fibroblasts, if you remember from basic science, blasts build cells. Fibroblasts would build tissue cells. Cementum, dentin, alveolar bone, pulp, those are all types of connective tissues. The interface between the epithelium and the connective tissue, it can be either wavy or smooth. So you've got your epithelium, you've got your underlying connective tissue, and this layer, this thin layer in between, can either be smooth or it can be wavy. So like in a sandwich, you've got two pieces of bread, and you can either have some kind of lunch meat or cheese in the between that's going to be smooth, or you can stick peanut butter and jelly, which is going to be more wavy. If you take your fingers and you lock your fingers together like this, the top part being your epithelium, the bottom layer being your connective tissue, this would be like what wavy would look like. So you've got these little projections that link together. They give it a tighter bond when they link together like this. Those projections, if they're coming off the epithelium, they're called reedy pegs. So the epithelial projections are called reedy pegs. And say if this is the epithelial tissue, these are the reedy pegs, and they're interfacing with the connective tissue. The connective tissue, the little projections coming off the connective tissue, are called connective tissue papilla. The two of them link together to try and form a bond. This is considered a tighter bond than if you just had these two laying on top of each other, where they could slide around a little bit. This is your wavy connection. This is your smooth connection. The epithelial cells attach to each other by desmosomes. So you've got an epithelial cell, and you've got desmosomes in between the two epithelial cells. So, and then the epithelial cells are attached to the basal lamina, which is the middle layer between the epithelium and the connective tissue. The basal lamina is connected to the epithelial cells by something called hemidesmosomes. So desmosomes connect the two epithelial tissues, and then or epithelial cells, and then the tissue connects to the basal lamina by hemidesmosomes. The basal lamina is that thin layer that attaches the epithelial cells to the connective tissue. It would be like the peanut butter and jelly between the two slices of bread. There's a really great picture of it on slide 21 in your chapter slides that show the way they interface together. Your oral cavity is made up of mainly of stratified squamous epithelium. And there's three different types of epithelium that you'll find in the oral cavity. You have oral epithelium, which covers the outer surface of the gingiva, and it's keratinized. So it's a little bit thicker and more tough, more rigid. It's got a protective function to it, so it's going to be a little bit tougher to protect. They may or may, they can be keratinized, or it can be parakeratinized. Parakeratinized falls in between keratinized and non-keratinized. So keratinized have no nucleus, non-keratinized have their nucleus. Para falls in between. It can be either have a nuclei or not, but it's usually in the wavy interface. And then you have sulcular epithelium, which is non-keratinized or permeable. So your sulcular, think about your sulcular epithelium. So you've got your epithelium, you've got your sulcus, and then here's your tooth. So here's your sulcular epithelium. It's very soft. It's non-keratinized. It's permeable because there's a fluid that flows through it called crevicular fluid. The crevicular fluid flows through it and lies in the sulcus. So you have, and that's in normal health. You don't have a lot of crevicular fluid, but the fluid does increase in flow as inflammation increases. It joins the junctional epithelium with a smooth interface, meaning there's no ridges. So as you slide down your sulcular epithelium, the base of the sulcular epithelium, where it attaches to the tooth, is called the junctional epithelium. And there's no reedy pegs. It's smooth. Think of it as nice, soft, smooth tissue. So your junctional epithelium is your last part. It's the base of the sulcus, just coronal to the CEJ. So you've got your tooth structure, and your tooth structure comes down and ends right here. And then you've got your CEJ, or where your cementum and your enamel meet. Right there is supposed to be where the base of your sulcus is, where the junctional epithelium is attached. This is all in health. Keep that in mind. So non-keratinized tissue can be easily penetrated, making it easy for bacteria to enter. So the junctional epithelium and the sulcular epithelium are non-keratinized. So they're soft. They can be penetrated easily by bacteria, which is what makes periodontal disease so easy. So when teeth erupt, basically when teeth are erupting, so they're going to break through the epithelium. So they break through the skin, the tissue. You now have an opening in the tissue. So bacteria theoretically should be able to run into that opening and have a party down in there. So in an effort to protect or keep that from occurring, there's a seal that's formed, and that seal is the junctional epithelium. So basically the junctional epithelium is designed to stop bacteria from going down the tooth. So as the tooth is erupting, the junctional epithelium is forming so that it will block bacteria from going down into the pocket. You have gingival connective tissue, which is also known as lamina propria. Do not get lamina dura from radiography confused with lamina propria and basal lamina. They are all different words meaning different things, but students always confuse lamina propria, which is your connective tissue, with lamina dura, which is that radiographic appearance. So your lamina propria contains fibroblasts, which produce extracellular matrix. So then there's something called fiber bundles. We're going to talk about fiber bundles. You have two different types of fiber bundles. You have your gingival fiber bundles and you have your periodontal ligament fiber bundles. Your gingival fiber bundles support your gingiva. Their function is to support the gingiva. They reinforce the junctional epithelial attachment to the tooth. They support your free gingiva against your forces of mastication and brushing. So if you think about when you take your toothbrush or when you're eating food and you are pounding down food or rubbing with your toothbrush against that free gingiva, something's got to protect it from continuing to just pull away from the tooth. And so your gingival fiber bundles are what keeps it tightly wrapped around the tooth. That's why when you can put your instrument in and you take your instrument back out after you've scaled the tooth, and your gingival margin or your free gingiva stays up against the tooth. It doesn't continue to break away. So your gingival fiber bundles support your free gingiva against the forces of toothbrushing and mastication. They connect the free gingiva with the cementum and alveolar bone. So they help protect the free gingiva and keep it attached to the supporting structures. And they also connect to teeth to adjacent teeth, so teeth that sit next to each other. There's 9 gingival fiber bundles that are discussed in your textbook. We're not going to discuss all 9 of those or memorize all 9 of those gingival fiber bundles. We only have about 5 or 6 of them that we're going to study really closely. They are named after their location. So just like some of the things we learned about, or most of the things we learned about in anatomy that are named after their function or location, so are the gingival fiber bundles. So as we're going through, it might be helpful for you in memorization purposes to create a mnemonic for them, but also it would be helpful as you're learning where they connect to. You'll find that the name matches pretty much. Like for example, you have alveolo-gingival. So those are going to connect the gingiva to the alveolar bone. You have circular. They're going to make circles around the tooth. Periosteo-gingival are going to run from the periosteum to the gingiva. So just kind of go through them like that, study them like that. We can talk more about them if you have questions down the road, but I want you to first have a chance to look at your PowerPoint pictures and see if they make sense to you. There's several pictures in the PowerPoint to help you understand where they are connected and what they do. So go through those. Then we have your periodontal ligament fiber bundles, and they are exactly what they sound like. Their function is to stretch from the cementum of the tooth to the bone. They fill the periodontal ligament space, the part that you've seen radiographically in Professor Bowles' class. That little space is all filled with these little elastic bundles. Again, they all have a function as well. They provide support to the tooth, so they help keep it in the socket, and they also can detect pain and tactile pressure. So in other words, if you bite really hard onto something and you get that kind of discomfort, sometimes that pain can come from the inside of the tooth. Sometimes it can be tactile pressure sensitivity. So as the tooth is depressed in the socket and those ligaments are stretched, they can sense that pressure On the ends of the periodontal ligament fibers are something called Sharpie's fibers. So Sharpie's fibers are described as brush-like fibers because they're very bristly. And so if you can imagine like the having a handle and then bristles on the end of it, of a brush, that's what these fibers look like. They string across, they span the periodontal ligament space, and the Sharpie's fibers attach on one side to the cementum, on the other side to the alveolar bone. So they're kind of like a string with these little hands or tentacles or fibers that come out and attach them. There are different Sharpie or different fibers, periodontal ligament fiber bundles, alveolar crest ones, horizontal, oblique, apical, and interradicular. So they, again, are also named after their location. And so there's a picture of the Sharpie's fibers on slide 48. It shows a nice picture of the way they bristle off the ends. And then the fiber bundle groups are on slide 50. So your alveolar crest fibers. Again, you're going to memorize these, but they're named right exactly after their location. So they all run from the cementum of the tooth to the alveolar bone. All of them connect cementum to alveolar bone. So the alveolar crest ones would run along the alveolar crest. So they would attach the cementum of the tooth to the bone at the alveolar crest. Horizontal fibers, they run from the cementum of the tooth to the alveolar bone horizontally. Oblique fibers, cementum of the tooth, alveolar bone in an oblique direction. Oblique being like diagonally. Apical fibers are located at the apex of the tooth. So they're going to run from the cementum at the apex of the tooth to the alveolar bone that's below the apex of the tooth. Interradicular fibers run along, they're only found on multi-rooted teeth because they're found in the furcation area. So they're kind of unique. They're not on every tooth. They're only going to be on multi-rooted teeth. And again, all of those fibers are going to span the periodontal ligament space. They're going to run from the cementum on the tooth to the alveolar bone. Their purpose is they act as like a shock absorber. So if you think about when you're chewing, they bounce a little bit so that your tooth isn't hitting, or the root of your tooth isn't hitting right on the alveolar bone. It has a little cushiony space. It's why you can sometimes, like when you torque your teeth and you get a little bit sore, you've stretched those fibers a little bit too much. In dentistry, a lot of times dentists will say to a patient when they say they had some pain, it's like kind of like bruising the tissue or the fibers. You've overstretched them, you've injured them, and now they're feeling this little bit of discomfort. People do that when they're clenching and grinding their teeth too. They're constantly working those fibers. Then we're going to talk about the cementum. The cementum covers the roots of the teeth. It's involved in tooth repair and regeneration. So, and it also seals the dental tubules from sensitivity. So you have those dental tubules that run in the cementum, or in the dentin, and they carry nerves, and when they're not sealed at the end, and you put ice or cold drink against your tooth and you feel that sensitivity, the cementum is what keeps supplies a barrier so that the cold from the ice doesn't get onto the nerve endings in the tooth. So it forms like a barrier. There's 3 types of cementum. They're described on slide 55, but basically they're an intermediate. So that intermediate cementum is located at the CEJ. Then you have acellular. Acellular are mainly Sharpie's fibers. They have no living cells within it. And then you have cellular cementum. Cellular cementum is the bulk of your cementum. It contains cementocytes and cementoblasts. So cementocytes and fibroblasts. Cementocytes are mineralized cementoblasts. Cementoblasts, like in all blasts, build. So cementoblasts build cementum. And fibroblasts make extracellular matrix and collagen. So they build extracellular matrix and collagen. They're located more in the apical and intraradicular areas. There's 3 arrangements that you can have of the enamel. I know we talked just briefly about this in dental anatomy, but your cementum can overlap your enamel. Most of the time your cementum overlaps your enamel surface. You can have where they are meeting each other evenly. So you've got your cementum and your enamel meet. And then you can have a gap between the cementum and the enamel so they don't meet. And there's exposed dentin. Those teeth usually have more sensitivity. You're going to find that to be the case when you are doing scaling and root planing. Teeth where the enamel and the cementum have a gap between them, that dentin is more sensitive. Sometimes that can create a problem when you're scaling teeth. Then we have your alveolar bone. Your alveolar bone houses the roots of your teeth. It is formed by osteoblasts. Again, blasts build, osteo being bone, so osteoblasts build bone. Bone matrix is rigid because of the deposition of 2 minerals, calcium and phosphate. So that's an important thing to know. Calcium and phosphate are what the minerals that make up alveolar bone. As we continue to go through our perio chapters, we're going to discuss more about all of these different tooth tissues, more in depth, about what else makes up alveolar bone and how alveolar bone is broken down. But for now, calcium and phosphate are the 2 minerals that make up alveolar bone. This is a nice summary of Chapter 2. So let me know or bring any questions with you to our online Teams meeting, and we can discuss things in further if we need to. Again, fiber bundles, periodontal ligament fiber bundles, gingival fiber bundles. Find ways to keep them separated. The periodontal ligament fiber bundles are going to all span the periodontal space from the cementum of the tooth to the alveolar bone. The gingival fiber bundles are going to support the free gingiva to the cementum of the tooth. They keep the gingiva standing up, so it doesn't just flop over like this. They keep it supported like that. And we'll discuss this further